everyone, this is Dr. Harika, one of the mentors in StudyMRCOG. So today I'm here, we are back with the back thesis series, which is for a module Antenatal Care. So I'm going to give little tips or a short video. This is a short video on how to approach a case of antenatal care. So the first thing is we always start with this quote: do not let a bad day make you feel like you have a bad day. Always keep practicing and keep doing things which actually help you for a better. So the most important cases, what we can expect in case of antenatal care module, it is a very vast module. Most commonly we see domestic violence, which can be a part of another module as well, because it is most of the time a hidden agenda. That's why I'm making this first in the list, because if you don't ask the history of abuse or history of any serious abuse in the partner or any serious. Should I start again, Sharanya? Hello everyone, this is Dr. Harika. I'm one of the mentors in StudyMRCOG. Today I'm back with, we are back with back-to-back YouTube series, and this video is all about how to approach a case of antenatal care module. So the most important cases, what we can usually expect in case of antenatal care modules are, as it is a very vast module, the list is never ending. The first thing which I have put in the list is domestic violence, because we usually get this domestic violence as a hidden list. If we miss it, there is a high probability that we are going to be marking almost all the cases. So always think that there is a domestic violence in any case, and then keep asking the history and the flow and the treatment and the preparation and the partner support. Then the other cases which can be there are one is substance abuse, and then teenage pregnancy. It could be severe restrictions, it could be female genital mutilation, female genital mutilation, could be congenital anomalies, or there could be a soft marker which is given in the report, and then we have to think about the soft marker, or any kind of anomaly, and asking for termination of pregnancy or asking for other implications, or it could be preterm labor, it could be maternity labor abscess, or it could be a case of obesity with or without a history of bariatric surgery, reconstruction counseling, or pregnancy, or it could be an antepartum hemorrhage or placenta with a jaw weakness, or it could be abruption without high blood pressure, and typical scenario also could be combined with abruption. Or it could be a registration, or it could be even specific for monoperiodic, diamniotic pregnancy, and so on in the list is an example. But these are the most common cases which we usually see in case of antenatal care module. Now, how to approach each domain? I will just briefly talk about each domain. As all of you know, what you have to ask in each domain. In addition to what you ask in routine, I have put forward little about each of the case scenarios briefly. So everybody should have their own template on information gathering, and in any case module, it is always important to finish the information gathering in about 3.5 or 3.5 minutes, or maximum 4.5 minutes. Maternal medicine module is the MD module, so it is the only module in which usually there is a slight possibility of information gathering taking a little more time. Rest of the stations you should be able to finish it in 3.5 minutes or so. So apart from the routine things, whatever you ask in information gathering, as most of the times after introduction, relating and agenda, you should be asked regularly complaints. In each scenario, like if it is a preterm labor patient coming to you, you have to ask them when she's having pain and what kind of pain. Is it continuous pain, or is it intermittent associated with any typing? Because you have to rule out if it is a preterm labor or if it is an abruption where she can have a continuous pain. And then if there is any leak of fluid, if it is a preterm pre-labor obstruct membrane, you have to always ask about when she is leaking, color of the fluid, rule out meconium, and then if there is a bleeding, rule out abruption, And if there is a history of fever, any thoughts in discharge, any pain in the tummy, all these things may need to rule out if there is an associated exposure amnitis, and if the breathing movements are reduced or not, all these things you have to ask in present. And always ask if the present pregnancy is a planned pregnancy or if it is an unplanned pregnancy, if it is a spontaneous conception or conception. Always in cases of emergencies, especially in case of antepartum hemorrhage, or if the woman has come with abruption, or in cases of eclampsia, most of the times whenever the scenario is given that the patient has come to you in ER and somebody from ER or triage has been calling you, in most of the situations, if she is in pain, they usually ask you to have a quick or relevant taking. In most of the times, if you have a triage document, go through the triage document and see that you they already will be giving you little information in that. Don't ask that information again. There should not be any repetition. So just quickly take the history, only that much required. So that is quick history or relevant history. Always simultaneous resuscitation is important in case of this emergency. And also you can ask if you would like to check the previous discharge summary if she has been pregnant before. And also in the present pregnancy, apart from the triage notes, apart from whatever they have given to you in the examination note, you can also ask them that you will go through the handheld notes of the patient in the present pregnancy, because sometimes the patient might not be able to give you the entire history as she is in pain. And then if she is in pain, always rule out the drug allergies and give the pain medication also, and check if she is comfortable, and only then go ahead and ask her. Always ask about ideas on future fertility, because a woman coming with a placenta excreta ending up in hysterectomy, you should be knowing what are the patient's ideas on future fertility. So that's why it is important to ask her ideas on future. In case of antepartum hemorrhage cases, one additional point, apart from routine history, you have to ask where does she stay, the distance from the hospital, the distance of the home, is it near or she's staying far, all these things. Accordingly, whether you can send her home or not, depending upon the amount of bleeding she had, is she having ongoing bleeding, and has the bleeding stopped or not, steroid given or not, and how far does she stay. Based on this, you can decide on whether keeping her in hospital for a long time or the distance. And in a case of previous history of bariatric surgery, now planning pregnancy, if she's come to you for pregnancy counseling, you have to always ask when the surgery was done, what type of surgery was done, is she been in touch with the dietitian, and how much gap she is supposed to actually have between the surgery and planning pregnancy. All these things you have to carefully check here. And then, yes, when you check the mental health, always important, rule out domestic violence, as I already said. Signpost where and when required. Always rule out substance abuse. Unless the woman is in labor, most of the times, there is no need of asking about substance abuse. And then in cases of fetal growth restriction, if there is suspected fetal growth restriction, they're given you a chart of an FDR or a baby, small baby or small phenotype. In all those situations, it is important to ask her occupation. Does she do vigorous exercise? Most of the times it could be a woman who is doing modeling or an actress or whatever it is. And ask if she is doing a vigorous diet or something. And check the OGTT report and the blood pressure report, because if there are any other associated medical conditions which are important for fetal growth restriction, and if the woman had herself is small at birth and the partner details also to some extent will play important role. And then in case of an FGM, in details you'll have to ask, in information gathering you have to ask, when was the FGM done, where was it done, mainly to check if it is a recent one or not. And then what were the symptoms, does she have any persistent pain even today, does she have any recurrent history of urinary tract infection symptoms, and then dysuria, any burning sensation in the urine, any changes in intercourse, does she have any flashbacks, what is her opinion about the procedure itself, and then what is her idea on getting it done to her baby, and if she had a previous girl child, has she had her child undergone FGM. All these things we have to ask in the interview. And yes, we all asked about drug allergies. It is very important in all modules. We'll have to ask about drug allergies and then get group and resolutions of their transmission. This is all the information gathering. Apart from the routine template you have, the routine things, whatever you have to ask, all those things like past medical history and past surgical history and family history, all these things, and then the smears, the sexually transmitted infections, the habits, all these things, where and when required, you have to definitely ask for it. Now, examination is also very important. You have to always talk talked about examining in the presence of chaperone. Take the consent, ask, can I examine in the presence of chaperone? And always justify when you're talking to the examiner. Usually, this could be in the module. It can be in the form of structured discussion or in the form of patient-related tasks. So whenever you're doing something, you have to justify. Say, I would like to examine her. To the structured discussion, I would like to examine her, and then I want to see what is the temperature, what is the pulse rate, because in case of any bleeding, the initial parameter to get affected is pulse, to see if she has any tachycardia, to see if she has any hypotension. So each and every observation when you're talking, you have to talk why you want to see for that. And then when you want to do a per abdominal examination, say if you're suspecting abruption, you have to say that I want to do a per abdominal examination to see if she has any uterine tenderness, to look for the height of the uterus, to see if it is contracting or not, to check for the fetal heart rate. With that, you have to talk. And then if it is a case of placenta previa, where you know that you can't do perspicuum co-vaginal examination, you can talk, I want to do a perspicuum examination to see how much is the bleeding and to what extent she had blood. And then if there is opening of the os or not, and to rule out whatever you want to rule out, that's what you're doing perspicuum examination, you have to do. And if you're sure that it is not a placenta previa, like previous cancer showing placenta in the upper segment, then if you're doing a vaginal examination to rule out preterm labor, then you have to justify that I'm going to do this for so much. So always when you're talking about something, it is always better to justify, especially when it comes to examination or when you're planning an investigation, or when you're talking about management plan, it is always better to justify, especially in cases of structured discussion. Now coming to the second domain, the second important domain is about the patient safety. In patient safety, always the first important thing which we talk is about the allergies, drug allergies, and then talking about the blood group and reservations. These two are very important. Wherein when indicated, yes, we ask if the woman is on aspirin or not, and if the woman is not on aspirin or less than 16 weeks, it is important to start the aspirin. And similarly, if she requires DVT prophylaxis, most of the times the need of DVT prophylaxis usually will be there in the case of maternal medicine module. So wherein when required, you have to start the DVT prophylaxis. Whenever you're given a report, if it is a report of a growth chart or a report of a scan or any other investigation chart, always check that if the name and the NHS number. You have to say that I have checked your report, confirmed your name and NHS number, because it can be Mary Johnson is the patient's name, and the name which is given in that can be Mary something else, like Mary Elena or some other name. The first name will be the same and the second name could be different name, and we just look at Mary, and that actually brings a lot of difference. So if you don't confirm the name and NHS number, and if you don't identify that the reports are wrong, then you'll be marked down in the patient's. So it is important that you mention that you confirm the name and NHS number, and then you talk about what it is, what the report is to the patient. And then in the patient safety only, it is always important in cases of antenatal care, because you should talk in the intrapartum care about IV cannula, about cross-matching, and about the continuous CTG. Most of the times, unless the woman is a low-risk mother, most of the times all these things will be required, because it is an either APH case or an abruption case or teenage pregnancy case, or it is a case of twins. On all these situations, and in case of all high-risk pregnancies, you will require an IV cannula, cross-matching, and continuous CTG. So in the intrapartum care, as much as possible, try to put all these things. Any emergency, it is important always first you should resuscitate. Without resuscitating, just don't go for anything else, because they see if you're using the word simultaneous resuscitation or not. It is a patient safety. And asterisk points, always there are few important asterisk points, like allergies and blood group reservation is one thing. In case of a DMAC continuous CTG is one thing. These asterisk points should never miss the asterisk points, because you'll be marked down in the topic. The other few safety points are, one is like in case of, say, a woman has come to you with high blood pressure, you should talk about safety netting advice, that what are the imminent symptoms, that is the red flag symptoms. When should she come to the hospital? What are the emergency contact numbers? This should be definitely counseled. Similarly, in a case of a bariatric surgery, if she has come to you for a pre-pregnancy counseling, you have to say better not to plan pregnancy for at least 1.5 years, and until that is the optimization of the medical condition kind of situation, because you want her weight to be optimized and you want her nutritional deficiencies to set in, so that once you actually manage all of them and optimize the nutritional deficiencies, then it is better for her to go in and embark on pregnancy. So it is important to talk about contraception if the woman comes in pre-pregnancy counseling with any kind of medical problem or any kind of medical situation wherein the optimization has not happened, then it is important to talk about the contraception. If the woman has come with the optimized medical problem, then it is important to talk about the folic acid. Okay. Yes, in the patient safety only, correct diagnosis and correct management and identifying the scan reports and all, and steps to risk mitigation steps also will come in the patient safety. What are the risk mitigation steps? Means, say if it is a case of placenta accreta, what are the main steps you are going to do to reduce the chance of the major obstetric hemorrhage? Similarly, any kind of medical problem, what are the steps you are going to do to reduce the risk? So that these we call as the risk mitigation steps. And in case of female genital mutilation, it is important to ask about the need of interpreter, because most of the time these people, they come from they are non-UK people or non-UK residents. So you have to talk about the need of interpreter, which is good with the language or not. If not, ask for interpreter. And if you don't know where to get the interpreter, just ask for the interpreter live. Okay. And then explain the UK law. You have to explain the law to the women that it is a crime to perform female genital mutilation in UK. And any women who's been taken, any UK resident who's been taken outside the UK to get these things also, it is not, it is a crime. And then screen for hepatitis C, screen for hepatitis B, and then HIV. You have to document and record and report. Always involve the consultant where and when necessary. And these buzzwords, few buzzwords are very important. For example, major obstetric hemorrhage protocol, MOH protocol, is very important in cases of antepartum hemorrhage, in cases of excess bleeding, in cases of placenta accreta and jabovid. Always check if there is an advance directive. If you override advance directive, override the autonomy, again it is, you'll be marked down in the patients. And this word CRIMA, it is not a buzzword. It is a word just to remember in case of any emergencies. Use the you have to use these things, that you will do a simultaneous communication, resuscitation, investigations, monitoring, and arrest the cause. If somebody has come with bleeding, you have to talk about all these things, because initially first we stabilize airway, breathing, circulation. You check for the IV cannula, check 2 IV cannulas, oxygen 15 liters, and then you give IV fluids, initial 2 liters of this fluids followed by 1.3 liter colloids. And then one person will be a scribble person, and one person will be sending all the investigations to the lab. The other person will be arranging for blood, and the other person will be involving the consultant. And all these things, everything will come in one single word called CRIMA. So if you can't talk about anything and if you are short of time, start with simultaneous communication, resuscitation, investigation, monitoring, and arresting the cause. And then each one of them you can elaborate and talk to the examiner. And then in a teenage pregnancy patient, it is always important, a safety point, to check the partner's age. This is mainly to rule out abuse. If the partner is like, say, if the patient is 14 years or 15 years and the partner is the classmate, like 14 or 15 years or even up to 63-4 years is also fine. But if the partner is, say, 30 years old, in those situations, you have to rule out abuse. Okay. So, yes, and then the next important thing is you have to talk about the applied clinical knowledge. In applied clinical knowledge domain, it is again a vast domain. Each and every condition you'll have to talk in detail about all those things. See, if it is a preconceptional advice, example, you've seen an obese lady, you've seen in preconceptional clinic, you have to talk about losing weight. You have to talk what are the benefits if the woman undergoes bariatric surgery, what are the risks if she doesn't, and if she embarks on pregnancy being on a obese BMI side. It is always important to talk that after the bariatric surgery, the lady should wait for at least 1.5 years, mainly to offer the optimization of the weight and for the nutritional deficiencies to set in, and then that will be treated. And then once in the antenatal care, always in case of any case scenario, it is always important you have to divide into antenatal management, intrapartum management, and the postpartum management. In the antenatal management, you have to talk about all possible maternal risks and fetal risks, and how do you minimize them, and what and when, how many number of scans are required, what is the name of the scan, why do you do the scan, and how frequently you do the scan. It's also important, you have to talk about it. And the frequency of antenatal checkups also, you have to tell how frequently the women should come. In case of a preterm or pre-labor rupture of membranes, always talk about tocolysis, need of steroids, and then need of magnesium sulfate, depending upon what gestation she's coming. And if there's an indicated gestation, you have to talk about these things. And what are the possible fetal risks, and put her in touch with the neonatal doctor for further counts. Similarly, in case of an antepartum hemorrhage case, talk about the steroids, magnesium sulfate, and if it is indicated, and if she falls into gestational age. And then talk about the blood products, need of cross-matching and saving the blood. Intrapartum care, there are only few points which have to be discussed in intrapartum care. You have to talk place of delivery. You have to talk it as a consultant-led unit or a midwife-led unit. Gestation-aged delivery, and then mode of delivery. And then in the intrapartum care, you have to talk if she'll require a continuous CTG, IV cannula, and then how you monitor the pain, what kind of pain relief options are there. All these things briefly you have to talk in the case of an intrapartum care. Always in the postpartum, you have to talk about the clinical governance issues. Need of clinical governance means you'll have to, in the postpartum, we usually divide it into clinical and clinical governance. In the clinical, in the postpartum care, say if the women had an antepartum hemorrhage, say she had an abruption with blood pressure, high blood pressure, you have to talk about giving the antihypertensives, continuing for a few days and tapering the antihypertensives, monitoring for the imminent symptoms, VOS chart, monitoring in the HTU, checking her amount of blood loss. If the blood loss is more, sending the lab samples, giving the blood transfusion, monitoring input-output chart, and the rest all in the modified early warning obstetric chart. Everything you have to mention. This comes in the clinical part. Coming to the clinical governance part, it is usually 4 Ds. You have to talk about the tactics, duty of condor if something has happened, and then need of DVT prophylaxis once the hemorrhage has been arrested or once the platelet count is more than 1 lakh. And then about the detailed discharge summary, how do you follow her up and what is the recurrence. So these things have to be spoken about in case of applied clinical knowledge. Registry, if there is a specific registry, you have to always talk about the registry. Always they see in the applied clinical knowledge, if you are being able to talk about what investigations are needed and if you're making an appropriate diagnosis or not, and you have to justify the investigations, and then whether you're being able to make a comprehensive mutually agreed management plan or an MDT agreed plan, and always you should have a backup or a contingency plan for all case of emergencies. And they also will see if you're being able to interpret the images properly. What are the images means? They can give you a placenta, percreta ultrasound image. So, and they see if you're being able to appreciate or identify it. At least you should say that this is what I suspect. So these are usual common things which you see in the applied clinical knowledge, apart from the routine things, whatever you answer. And then next, coming to the communication with the patient. In communication with the patient, as we all start initially, it is the most easiest domain. The most easiest domains, I feel, are communication with both patient and communication with colleague, because they are more or less same for almost all modules. So initially, greet her, ask how she is doing, and then confirm her name and age, and then ask how she should be addressed. And making an agenda is very important. Always you have to tell that so and so person, right? And I can see that you have come with this thing, and this is what you want. Am I right? Is it so? So if you have to, always have to make an agenda, because I see most of the usually candidates don't make an agenda. So it is very important to make an agenda. And then empathy and sympathy, no jargons. It is very important. Try as much as possible to talk in non-medical or layman's language. And then where and when required, draw images and show. You'll be given a pencil and book. So draw images and then you just show and check the understanding. Always give info in chunks. After talking 3 or 4 sentences, give a break and then ask, am I clear so far? So check the understanding. And when you're giving treatment, always give all the possible options if it is possible. Like in case of VBAC, you can't tell that if she's not willing for a continuous CTG, you can't tell that I negotiate, okay, for some time we can skip the CTG or nothing like that. You have to say if it is really possible, give all options and let them decide what they want. That is informed decision making. In case if it is not safe, you have to tell, sorry, I cannot do that. It will be too risky because you might be affecting the patient's safety, because you'll be marked down on the patient's safety. And yes, if there is a mistake somewhere happened, always you can say sorry, but only say sorry once, do not repeat. And in the case of breaking bad news, ask if she's being accompanied by somebody or not. If there is nobody, ask if she wants her midwife or sister to sit with her. And then you can say that, sorry, I don't have a good news for you. Give a warning shot. And then you can say that I can't even imagine what you must be going through, all those things. And in communication with the patient, in the end, you will have to talk about patient information leaflets and support group addresses, peer supports, and you have to say that you will document the consultation. Okay, this is about communication with the patient. Next, coming to the communication with the colleagues, always in communication with the colleagues, MDT is the keyword. Always involve the multidisciplinary team. It will be senior consultant, senior pediatrician, anesthetist, urologist, cardiologist, pain management, counselors. In case of placenta accreta spectrum, you have to talk about intraoperative cell salvage, and then checking the technician, the hematologist, blood bank people, and then the complex pelvic surgery expertise person available or not, the interventional radiologist. All these things, they come under MDT. So MDT is one buzzword in the case of communication with colleagues. And then if the consultant is away, you have to tell, sorry, consultant is away. Can I take this consultation? And once I am done with this, I'll discuss with consultant and get back to you. So you can say that. And it is important to say sorry when the consultant is away. And if the patient is referred by a GP, write back to the GP. If the patient is referred by a midwife, write back to the midwife. In all cases of structured discussion, it is very important to talk in S-bar format. That is how you will be marked. If you don't do it in S-bar format and if you just go to the final diagnosis or the provisional diagnosis or the differential diagnosis without giving us S-bar format, you will be marked down in the communication. To add on here, labor ward prioritization also there are so many things which come in communication with the colleagues there involving MDT, and also allotting the cases to different people who are there in your team. That also comes in the communication with the colleague. Okay. So now let's talk about few do's and few don'ts. I'm just giving few examples. There are many examples actually. It is also an exhaustive list, but to talk about few. When it is specifically mentioned to you that you have to take a relevant history, example, the patient is in labor, what you have to do is first check if the patient is comfortable giving quick history or not. Because if she is having pain and you keep on giving questions, she will be again acting the pain again and again, because the role player is an actor. The role player will be acting till you ask, are you comfortable to give history? And the minute you say that line, they say, yes, doctor, I'm comfortable. Then you have to check first line, do you have any drug allergies? Do you want me to give you some kind of medication for pain relief? Okay, so then they'll be okay, then you can give a medicine, and then only take quick relevant history. Whatever is given to you in the candidate instructions, please do not again ask those questions, don't repeat. Only ask the relevant quick history for this person, whoever is in labor. Don't ask for smears. It will not actually be useful here. Don't ask for sexually shared infections or habits like she smokes or drinks alcohol. All these things, it will not be useful here. If it is a case of abruption, yes, it can be. So think about the relevance, and if it is really relevant, then you have to ask, if not. Next, again, in the patient with in labor with pain, as I already said, do not prescribe the analgesic without ruling out drug allergies. Some they prescribe analgesics for the pain. It is good, but because you didn't rule out drug allergy, later they mention that the patient will have this kind of drug allergy and you gave the same medicine, and they'll mark down in the patient's. Okay. And the other scenario, say if the patient is less than 25 years old and they ask you to take relevant history, you should not ask. So many candidates who ask about smears for patient less than 25, patient coming at 23 years to you for pregnancy, low risk, you should not ask about the smears. In the teenage pregnancy, it is very important to build rapport. Teenage pregnancy, you straight away go ask, can I ask you some questions, and then you start something? No. Just greeting and then asking what is your name and age, and then making agenda and going, can I ask some questions, also will not work. Build some rapport with the teenage person, whoever is sitting in front of you. Ask how is everything at school, how is everything at home, and then let them be sure that you are non-judgmental, and make her comfortable, and then only go ahead and ask the history. Whenever you're talking about the partner, don't use the word partner, use the word boyfriend for the teenage. And always in women who are less than 25 years, it is important to rule out sexually shared infections because the incidence of chlamydia is very high. Now, don't ask the history without building rapport because she'll start behaving insensitively and she will not give us to treatment. The other scenario is if somebody is allergic to aspirin, see, we read the scenario and we will understand that there is indication for aspirin. We will prescribe aspirin and we'll think, Kamaya, patient safety, we haven't missed it. But actually, somewhere it will be given in the corner or in the last line that the patient is allergic to aspirin, and there we lose again the patients. And the entire domain, they mark the stop. So yes, nowadays we've been seeing scenarios mentioning in specific about allergy to aspirin. So please, before prescribing aspirin, cross-check and see if the patient has any aspirin allergy. And coming to the abruption patient in specific, in the abruption case scenario, they'll mention that the NICU is not available, NICU facilities or tertiary level NICU is not available. In those situations, we think abruption is there, NICU is not available. We'll forget abruption, we think it is antepartum hemorrhage, and we'll talk about in utero shifting. No. An abruption, it's always emergency. You will have to do a relevant history and resuscitation simultaneously. 3 buzzwords. First buzzword is relevant history and simultaneous resuscitation. Second thing is immediately you will do an ultrasound, mainly to rule out the women didn't have an IUFD, and then cross match and blood group and save the blood. And the fourth important thing is do an immediate delivery and shift the baby after the delivery. Do not do in utero shifting for a case of abruption. In utero shifting can be done in case of a preterm pre-labor rupture of membranes, or in case of early preterm labor where the patient is not actually progressing rapidly into labor and then the NICU is not available. Then you can make the patient being accompanied by with the senior midwife or whoever is competent enough to take care of the delivery in case if it happens on the way also, and only then you can shift. But otherwise, in all cases of emergencies or abruption or eclampsia patient, in all those situations, you have to stabilize the patient and deliver the baby, and only then you can do the shifting. Don't do in utero shifting. Next, in case of an antepartum hemorrhage, always rule out placenta previa first. Do not do per-vaginal examination before ruling out placenta previa. Instead, you can do per speculum examination to assess the extent of the bleeding, or if you want to see if the patient is in simultaneous labor or not, so then you can do a per speculum examination, but not the per-vaginal examination. Say the another scenario, a VBAC patient who is not agreeing for continuous CTG. Here you have to do not oblige or negotiate. Don't say that half an hour I'll do the CTG and then later you will make the patient on to the CTG or something like that. You have to tell that it is very important to monitor the baby with continuous CTG as you have a scar on the uterus and we don't know when the scar can suddenly give away, and in those situations every minute counts, and that it is too risky to keep her without continuous CTG, which you will not be able to do. Okay. And you can also involve the name of your senior consultant and you can tell her that I'll make you talk with the consultant and this situation is too risky. You can handle it that way, but do not oblige her, do not allow to her negotiate. Few important cases, little briefly, I wanted to talk about these things. I felt in this station, the antenatal care station, the most important ones are antepartum hemorrhage, abruption, Jehovah Witness, female genital mutilation. Couple of them, I felt them very important. And most of the times, antepartum hemorrhage, abruption, Jehovah Witness, it will be in the form of a structured discussion. So always try talking only to the point or to the question. Do not actually talk anything beyond what is asked. So the first important thing is antepartum hemorrhage. Only few points I'm talking. You have to ask about associated symptoms of abruption, any pain in the tummy, and then how much is the bleeding. And you have to ask the distance from the home. Rule out, ask you if it is associated abruption, ask any history of high blood pressure, any imminent symptoms. And rule out previa by checking the previous scans, or you can also do a bedside scan, and then only you have to do a per-vaginal examination if you are sure not placenta previa. If not, do a per speculum examination. As I already said, grouping and saving, blood grouping and anti-D accordingly. If you feel that the hemorrhage is more, do a KB test to see if you have to assess the feto-maternal hemorrhage and if you have to give further doses of anti-D.
If the gestation falls below the indicated gestation, you have to give steroids and magnesium sulfate. Antepartum hemorrhage, active bleeding, we usually don't give prophylaxis. Always talk about the major obstetric hemorrhage protocol if the bleeding is significant. It usually includes involving the senior obstetrician, senior anesthetist, and what steps you will be doing, grouping and saving, and then blood product saving. All these things, they come under the major obstetric hemorrhage protocol. And then coming to the abruption, usually they give the abruption with high blood pressure scenario. So, and patient will be in the pain. You have to rule out drug allergies and give pain relief. Quick, focused history, simultaneous resuscitation, all that airway, breathing, circulation, IV fluids, how much 2 liters crystalloids, 1.5 liters colloids, labs, sending the lab investigation, checking with the hematology, blood transfusion lab, and then starting antihypertensives. If imminent symptoms are there, giving magnesium sulfate. All these things are also very important, which have to be considered. Check the triage documents and the handheld notes always to see if you're missing on something. And then if there is a history of smoking or drug abuse or trauma, because they are precipitating factors or they are risk factors for abruption, you can quickly ask about it. If there is any associated pain with the bleeding or not, what are her BP recordings, any imminent symptoms, immediately do a bedside ultrasound to see that the baby's heartbeat is there and it is not an IVF. Then you can discuss with your consultant and make a comprehensive plan, and mutually agreed plan after discussing with the patient. Most of the times in these situations, abruption, it will be immediate delivery. Next, Jehovah's Witness, it is important to ask or see if the woman has an advance directive, what blood products she allows, or is there something she allows us to give or not. And then do not override her autonomy. Intraoperative cell salvage word has to be used. You have to also check the availability of the machine and check the availability of the staff or technician, because everybody will not be able to operate it. And pre-operative optimization of hemoglobin should be done. If the woman is willing, you can do autologous blood deposition 3 to 4 weeks prior. And then counsel everything and document explicitly. In cases of emergency, you can tell that any time the woman can change her decision and let us know. You have to talk to the women, that the women who are Jehovah's Witness, their outcomes in kind of situations like this are poor when compared to women who are non-Jehovah's Witness, and you should tell this point to the women so that she can make a decision or change her decision as and when. In case of an unconscious patient, it is important to talk about important to see if she has an advance directive. If there is no advance directive, always act in the best interest of the patient and involve a senior obstetrician or a senior consultant for a second opinion, because the patient is unconscious and Jehovah's Witness and no advance directive, and also involve hospitalization. Now coming to placenta accreta, usually they give you a scan report, and then it is like you have to again confirm the NHS number and name and talk to the women. It is similar to the Breaking Bad news station. Check if somebody is there or not, give a first warning shot, and then talk about it. As and when required, consider MRI. Most of the times it is better to consider MRI. And then explain maternal and fetal risks, what can happen, which is again a very big list. And you have to make an agreed multidisciplinary plan 3 to 4 weeks prior planning the delivery. Usually we plan delivery in placenta accreta around 36 weeks. So before that, around 30 to 32 weeks, a plan should be made. And the options which we usually give is, one is do straight away after doing the classical cesarean, you will do a hysterectomy, leaving the placenta in situ. You'll go ahead and do the hysterectomy. Versus if the woman is keen on fertility, then leaving the placenta in situ, closing the incision site, followed by methotrexate versus triple reposition. So these conservative options, they are not really safe options, and they only have to be done or spoken about in case of women who need future fertility. Always the placenta accreta should be managed in an tertiary center, MDT word should be used, with access to interventional radiologists, intraoperative cell salvage, specialist surgeons, neurosurgeons, senior pediatrician, and senior anesthetist, and complex pelvic surgery expertise. Plan steroids in these cases way much ahead, and GS4 and steroids before 32 weeks, and plan delivery around 36 weeks. It is always better if it is done in an elective manner because of the complications that can happen in the need of multiple blood and blood products at the time of the surgery. But in 20% cases, they can end up in emergency. So you should have a backup or a contingency plan. Now, domestic violence, the most important thing in domestic violence is most of the times it is a hidden agenda, and 20 to 30% candidates, they will not pick up this agenda, and they'll lose points over there. If you actually pick it up, the answering is very easy, straightforward. They usually come either for multiple visits in the form of a gynec. It could be a gynec module coming with vaginal discharge multiple times. Usually that is the most common way they present, but they can also come for antenatal checkups, which are not really that many required, or they are very much shyful or resilient. They refuse examination mainly to cover bruises. So these are different cues which they give, and you have to pick them up. If you have a doubt also, even one person, you can tell them directly that there is something called domestic violence, and women in UK, usually 1 in 10, they face this. And we usually talk about this to every pregnant woman who come for antenatal checkup to be on a safer side. And you say that for this, we offer support and we maintain confidentiality. Anything you can please speak up to us. We are there to take care of the situation, is what you have to tell. And then if she's sure and if she comes out that there is something domestic violence, then you can talk about the child abuse. If she says there is nothing like that, then you can leave it there. Next one is important thing is MCDA twins. Usually MCDA twins, most commonly it will come in the form of a structured discussion, especially a twin to twin transfusion syndrome, because the patient can come with sudden abdominal distension, sudden severe pain in the abdomen when she's having twin to twin transfusion syndrome due to polyhydramnios or something, or breathlessness. That is how usually they ask. Sometimes it also can come as an MCDA twins coming for booking visit. She knows that she is twins and she's excited, but she didn't know actually it is an MCDA twins. Here you have to explain what is twins and what does MCDA twin means. You have to draw and explain. There is an exhaustive list of complications that can happen to the twins. So you have to talk about all maternal complications and all fetal complications. Then in specific, what are those complications that can happen to MCDA twins? Sorry, here I wrote MCMA in the third line, but it is MCDA twins. So you have to talk about all the twin to twin transfusion syndrome, the trap, the TAPs, so all those things which can happen in the case of in case of an MCDA twins, the single fetal growth restriction, the single fetal demise, and then what can happen, everything brief. In any case of twins, you have to talk about frequent antenatal checkups, need of frequent scans, depending upon what is the chorionicity, the frequency usually changes that you have to talk. And again, what is the antenatal care? How do you manage in the intrapartum care, which is more or less similar to any high-risk pregnancy? And then you should talk about the mode of delivery, timing of delivery, and the possibility of even double delivery. You should talk in case. And then it's coming to the congenital anomalies. Usually they give you either a congenital anomaly or they give you a soft marker like an intracardiac echogenic focus or an echogenic bowel or something like that. And then you have to describe exactly what it is to the women, and then you have to tell what it could be associated with, and if there are any possibilities of associated anomalies, you have to talk to them. And most of the times, what are the chances of recurrence? And if it is not something harmful, you can reassure. If it is suspicious of some trisomies or something like that, you can offer them. You can tell them that you will discuss with your consultant, and you'll also discuss with your fetal medicine specialist. And as per the need, if it is required, you will do an amniocentesis based on the gestation, and then accordingly, we'll further get to know those things. You'll have to talk in case of soft markers if you think they are really very much important. Always it is important to talk about that it is not her fault, because most of the time if it is an anomaly, the women can be sitting and crying. Partly like a breaking bad news, you have to confirm the name, NHS number, and talk to her. And then in a non-blaming attitude manner, you should actually reveal that this is the problem and this is what it has to be done and this is how you should follow. Coming to the female genital mutilation, as we already described, we need to check if she needs an interpreter, and then always explain the female genital mutilation law and that it is illegal in UK, and ask where and when it has happened and about the relevant symptoms, everything which we have discussed in information gathering. Check the smears, check the HIV, HBsAg and HCV reports, and reporting and recording are very important. Talk about HSCIC. And then important to talk about the safeguarding. It is very important to document in all the places the vaccination of the female child in the discharge summary and all those things you have to talk. You have to talk where you will be doing the defibrillation, the timing, when at what gestation you will be doing, or in the labor you'll be doing, and what is roughly the procedure. Or if she undergoes cesarean, post-cesarean, you can do all these things. You have to talk. And you have to tell that under any circumstances, re-infibulation will not be done. Always involve the MDT. You should always involve a senior midwife and a senior named obstetrician who has special interest in HGM. Okay, safeguarding people also we should involve, and include the counselors, because most of them they have either some kind of flashbacks or they feel low or something. Now, this is the last important case which I want to discuss is, yes, obesity and bariatric surgery. They usually ask about what are the types of bariatric surgery. If it is a structured discussion, they ask you about WHO classification, what are the types of bariatric surgeries, what are the possible complications and all. And the women can come to you in a patient-simulated task for a preconceptional counseling. In that cases, you will have to explain what are the possible risks in the pregnancy post-bariatric surgery. Usually, most of the times it will be nutritional deficiencies, inappropriate or less weight gain, fetal growth restriction, having complications of one of the procedure, having gastritis, reflux, all these things usually are common, so you have to talk about them. And in the time of cesarean, what problems can happen? Yes, slightly increased chance of cesarean section is there that you have to explain. And despite the procedure, if she's still on the obese side, you have to talk about all the obesity risk factors, risks that can happen to the mother and baby in the pregnancy. Yes, benefits of bariatric surgery, they might ask you. You will have to say that there is increased chance of spontaneous ovulation after that, better response to IVF after that, the reduction in all the complications that can happen in the obese women in pregnancy, reduced chance of GDM, reduced chance of hypertension, these things you have to talk. Always in preconception care, tell the women that we should wait for 12 to 18 months and only then plan pregnancy. And then talk about the need of high dose folic acid. Early pregnancy, you can start low dose aspirin. Involve the dietitian, proper nutritional supplementation is very important. OGTT cannot be done as it can cause dumping syndrome. Instead, offer fasting and post-lunch or postprandial blood sugars testing to diagnose GDM in pregnancy. Talk about ideal gestational weight gain, how much it should be there, and involve the dietitian, they'll take care. And explain about the possible complications that can happen and the chance of band slippage and intestinal hernia which can happen in the pregnancy in a woman with bariatric surgery. I hope this helps. Wish you good luck. We are offering all these courses and we'll be back with other modules, videos also. Thank you.